Hello everyone, I am Dr. Mythri Shankar, Associate Professor in Nephrology from Institute of Nephrology, Bangalore, India. It's in the southern part of India. I'm also a member of the World Congress of Nephrology social media team. It's a privilege to welcome Professor Vivek Bhalla and Professor Anuja Java today. Over to Dr. Sayali Thakare.
Hello everyone. So I'm Dr. Sayali Thakare. I am an assistant professor at KM Hospital, Mumbai, and I'm also a part of the WCN'25 social media team. I'm really glad to have you here at the Kidney Studio with us for a session of question and answers. So we'll introduce both of you to our audience. Dr. Anuja Java is a transplant nephrologist at Washington University, and she focuses on functional consequences of genetic variation in complement-mediated diseases. She co-chairs the NIH-funded Clinical Genome Resource Complement Gene Curation Panel and is a leader in post-transplant care for patients at risk of recurrent glomerular diseases. Dr. Java recently, in 2022, received the National Kidney Foundation's Award of Excellence for her impactful contributions. We are really looking forward to hearing you today.
Thank you, Sayali. Wonderful to be here. It's an absolute pleasure.
Professor Vivek Bhalla conducts NIH-funded research on tubular transport mechanisms in diabetes and hypertension. As founder of the Stanford Hypertension Center, his research explores aldosterone and insulin's role in blood pressure regulation. He is also a co-PI of the Renal Science Core for the U01 Cure Consortium, focused on CKD in developing countries, and mentors numerous trainees. Welcome, professors. It's a privilege to celebrate your outstanding contributions to the field of nephrology.
Thank you so much. It's an honor to be here.
Professor Anuja Java, the first question is for you. Can you describe the most significant challenges and breakthroughs in understanding the genetic variants involved in complement-mediated diseases throughout your career?
I consider original complement moving. And so what had happened at the time was that clinically we were seeing patients with traumatic microangiopathy, and these patients were getting a transplant and losing their allograft after a transplant because the diseases were not recognized pre-transplant. Genetic testing had just started happening. It was like maybe one or two places that were doing it. And so we identified variants in these patients that had a pretty bad outcome after transplant. And these variants were variants of uncertain significance. And so I had just started, bench training in the complement lab. So I learned to make these mutations recombinantly. We would express the mutant protein and we would do functional assays that actually John in his lab had been doing. So John has contributed extensively to the field of complement in the understanding of this function of complement protein. And then we would use that data that we got from our functional information for, making decisions for our patients. And this was, like I said, back in 2011. And during that time, and even, over the years, multiple labs like David Kavanaugh's lab, Veronique's lab, Richard Smith's lab, they've really, they've done all this functional data and a lot of progress has happened. So I think when you ask me in terms of big breakthroughs, I think, our understanding of complement has improved. The number of labs that do genetic testing has gone from 2 to maybe 10 or 11 labs. The cost of sequencing has gone down. And in terms of challenges, I think that still remain is that it still takes 6 weeks for us to get genetic test results back. It's not faster, so you can't use it to make imaging clinical decisions. So functional testing is still lagging behind. What I learned to do, even though it's kind of the gold standard, it takes months. You need a dedicated technician, you need money and effort. So I think what we don't have in the understanding is being able to do something very quickly and being able to make a decision that, we're getting there. So I think we've made a lot of progress and there's still a lot to be done.
Exactly. From your experience, we clearly understand the importance of functional assays in variant of uncertain significance. That is one thing. And also how to speed in or how to fasten the results that we can get when we send for testing. That's again something which we have to work on in the future.
The papers have been absolutely fascinating to read. So I've been going through the functional assays that you have worked on, and they seem to be like explorations which are not possible in any other center. It's really fortunate that you are working with a team that brings this research out.
That's
Yeah.
100% right, Sayali. These are only available in specialized labs. And so, I think the eventual vision would be that we would make these maybe serum-based rather than having to do them recombinantly and be available much more, faster. So, and I don't think that that's impossible. I think it's possible. It's just that you need money, time, effort, dedicated people to be able to do that.
Yes.
Yeah.
So thank you so much. Dr. Bhalla, the second question is to you. Your research on tubular transport mechanisms in the context of diabetes and hypertension has been pivotal. It's been pioneering. Could you share some insights on how your focus evolved into this area?
Sure. Thank you for the question. I think I'll also start uh, just back in time as to how I got into this field and how I got into tubular transport and what it's meant for both aldosterone regulation and insulin regulation. So I did not intend to work on tubular transport, but when I came to fellowship, I was inspired by my mentor at the time, Dr. David Pierce from the University of California, San Francisco, who had been working on mediators of the pathways how aldosterone, a very commonly known hormone, would stimulate sodium transport and all of the intracellular machinery from that point forward. So I began work in that laboratory with very little basic science experience. And I think, as Dr. Jaffa pointed out, that one can do all of your clinical training and then focus on basic science. And that was my experience too. And then I began to understand better how aldosterone regulated ENaC. We published some papers in that regard. And then when I started my faculty position, I wanted to work on that a little bit more, but I wanted to shift a little bit from aldosterone regulation to insulin regulation because I felt at the time that we knew hypertension had a number of potential risk factors, one of them being insulin resistance and concomitant hyperinsulinemia. So the hypothesis that I started with when I started my career, I've since disproved, but it was the idea that insulin would regulate ENaC, and that would be a prominent cause of hypertension. We went forward and found out that in many of the models we looked at, insulin did not have a prominent role in the regulation of ENaC. It still had a prominent role in the regulation of sodium transport, just by other mechanisms within the proximal tubule of the kidney. And then we started to subsequently look at insulin's role in other forms of tubular transport. But then coming back to ENaC, it's interesting. I also see patients. At the time, I was seeing patients about 10% of my time. And I saw a patient just by happenstance that I thought had ENaC-mediated disease. And when I was in the laboratory, we're conditioned when we're looking for funding for research grants, we're conditioned to bring up the most most prominent reason why our research will be significant. And for anybody working on ENaC at the time, any grant I read, any paper I read, it all whittled down to one syndrome, which affects only a handful of patients in the country. I run a hypertension center, and I've never diagnosed a patient with Little syndrome, yet I did all of my research in ENaC-mediated sodium transport, and yet said that it was so important that you should give me money to continue research in that field. And so as I went forward, though, I happened to see a patient with hyperaldosteronism in clinic and realized that form of ENaC-mediated sodium transport and that form of pathology is way, way, way more common and is very poorly diagnosed, and most nephrologists don't focus on it. Most endocrinologists, cardiologists, and primary care physicians do not focus on it. And I began to look into it more and look into the reasons why it was important, look into what was known about the pathology, both from the side of aldosterone and from the side of ENaC, and just got very interested in going forward from there. So that work has become quite translational now, and continuing to look at that more really from the hypertension side. And so much more than just the few patients with Little syndrome. And so I guess what I'm saying is that the regulation of ENaC has been a common thread since I was a fellow to my years as a junior faculty to more senior faculty now.
Would you call hypertension a renal tubular disease, really?
I absolutely would. I absolutely would. I feel that the way that hypertension is cared for in the United States and probably around the world is it's done in various silos. So many patients are seen by a primary care physician. But then if you ask a layperson, if you ask somebody who's not in the medical field, if you have hypertension, who should you go see? And my wife's a cardiologist. I'm going to get killed for this, but it's always a cardiologist that is recommended, and it's patients that want to see a cardiologist because that is where their education and learning has come from. That cardiologists see patients with that they see complications of hypertension, and so they're the person who to go to. But I don't feel that that's true. And nephrology training is many things. It's training for acute kidney injury, chronic kidney disease, glomerular disorders, transplant, and hypertension. And many of the divisions of nephrology around the United States and probably around the world are truly divisions of nephrology and hypertension. And so going back to the principles of Arthur Guyton, hypertension is a kidney disease at its core, whether hypertension is the cause or the consequence or the contributor. Hypertension at its core is part of what we do in nephrology. And so I've tried to continue to build on that as I've gone forward.
Amazing. So reclaiming the territories back to nephrology. Yes. Thank you, Dr. Bhalla.
I think it's time we appraise our cardiology colleagues and let them know that hypertension is
Yes. Reclaim the
our
territory.
disease, not yours.
And I have to say that cardiologists know exactly what to do, and they are the best equipped to deal with complications of hypertension far more than nephrologists. But from the diagnostic side of it, I think both specialties need to be involved, as well as endocrinology and obviously primary care.
Professor Anuja, here's the next question for you. So you are working in the field of transplant nephrology, which is very demanding. So how do you balance doing transplant nephrology, seeing your patients, and also clinical research at the same time?
That what I do right now is not traditionally how things are done in most centers. You're either more committed to clinical work or you have more protected kinds of research. But I'm more like 50-50 or 60-40, and that is something that I actually chose to do because I couldn't let go of either arm. So to really be able to do it, the brutal truth is that I work a lot. I work weekends, I work nights, whenever I'm not doing clinical work, I'm involved. But I really don't even consider that work because that is something I truly love and enjoy. And so if I wasn't doing it, I would be more stressed out. So it's a matter of doing what you love and keep at it. So it's just a lot of work, but that's how I prefer it.
Yeah, basically clinical research is passion driven, and you both of you are living examples of it.
Many lessons for you and me, Mythri. So, Dr. Bhalla, mentorship has been a big aspect in your of your work. So, can you share how has it impacted your journey and journey of others with whom you have been mentored?
Sure. I think so. Mentorship is a two-way street. I'll start with that. I think it's very important when one talks about mentorship to talk both about who your mentors are and your sponsors, and then also to talk about your mentees. On the way over here today, I was thinking about this a little bit. Everything that I did or was involved in or got any credit for in training or early on, I attribute to my mentors and my sponsors. So I attribute to Dr. David Pierce, who got me interested and really taught me how to do basic science research. I attribute credit to my sponsors also, Dr. Glenn Chertow, who's a world-renowned clinical trialist in nephrology, who really looked out for opportunities for me, Dr. Thomas Clayman at the University of Pittsburgh. These folks and many others really helped shape me as I started and helped me take the passion that I had in basic research and be able to apply for grants that I didn't think I would get, submit papers to journals that I didn't think would get accepted. So I think I learned a lot from my mentors, and I think that that is really important to have. Nobody can do this alone. You heard what Dr. Java said about how she was inspired to look at complement mutations in the lab of a prominent scientist. Nobody can do this alone. Um, and when you are being mentored, you realize that the situation that you come into is a very sensitive situation. So you finish your clinical training and then you want to focus on research, or you want to focus on clinical care, or if you want to be mentored in hospital administration, or you want to be mentored in how to be a good clinician, it's a very narrow relationship. There's just you and the mentor. And so if that relationship does not go well, um, they can become a tormentor in many ways. If they singularly have a very large influence in your career, they have a singularly large influence in your success, in your happiness, in what you find interesting and passionate to work on. And so you have to be lucky, but you also have to realize that um, if the situation that you're in is not necessarily a productive one, in your opinion, that it's important to look elsewhere, because you can have additional mentors or alternate mentors depending on the situation. And I am very fortunate that I did not have to do that. But I know plenty of people who came into the field with a lot of passion and weren't able to um, proceed from that point because of a less than ideal mentor-mentee interaction. I think then going forward and looking at mentees, when I started my own lab, I all of a sudden had mentees. And the first thing that I realized was that there was nothing in my training that prepared me for that whatsoever. We go through and we learn the Krebs cycle. Finally we learn what a nephron is. You pass your boards, you pass your exams, you do all of your clinical training, you learn how to take care of patients. And then finally, in the science world, you learn how to do experiments, you learn how to write papers, you learn how to get grants, then you learn how to buy equipment. And I had no idea how to be a mentor. That training never comes through. It comes through in other fields like business, politics, and other fields. You learn how to mentor, not in medicine. And so it's very much on the job training. And I don't know, I can say that I probably made quite a few mistakes when I first started, but I think afterwards I kind of got the hang of it. And I think you have to learn to adjust to the passions of your mentee. So if your mentee is not necessarily as passionate as you are about a particular experiment or about a particular research question, you have to adjust to that. If your mentee wants to work on something slightly tangential to what you want to work on, you have to adjust to that. If your mentee's goals are not aligned with yours, you have to adjust to that. And you really have to support your mentee in whatever they want to do, because, as I said at the outset, this relationship is quite narrow, and what you do directly impacts their success, happiness, and their career. And so I have tried to teach by example, that I'm passionate about the work that I've done, and I hope them to be passionate also, and to try to get them excited about what we're doing. And I think I've gotten a little bit better at it as I've gone on. I've had the opportunity to mentor on a little bit larger scale, in the sense that we now have students coming to Stanford for the summers to get interested in kidney disease and neurologic disease through a very generous grant from the National Institutes of Health in the United States. And then I've just tried to learn from the examples of the mentors and sponsors that I had, and how they taught their mentees what worked, what didn't work. And it's an ongoing education, actually.
Very nice hearing about this whole experience, your mentor and your mentees both together. Very considerate thoughts you put up.
Thank you. I should actually say one other thing, is that I said at the outset that everything that I did or got credit for, I owe to my mentors. You now learn, when you're on the other side of that coin, that everything that we've published since then, a lot of the credit goes to the mentees, because they are the ones who did the work. They're the ones who ran the Western blot at 6 p.m. when their kids, needed to be picked up from school, and yet they spent the time doing the work. And they're the ones who were up late at night writing the paper. And so it's a very important relationship. And it's always important to recognize how much work the other person is putting in. It really helps cultivate that mentor-mentee relationship.
We'd really say they're lucky to have you as a mentor.
Thank you. Thank you.
It's true about mentorship, finding a true mentor who who feels happiness and who feels fulfillment and success in the mentee success is very difficult. I truly agree with that. It's difficult to find an ideal mentor, and we are very glad that you've been mentor to your mentees. I think your mentees must be very fortunate, and we are also mentors right now. She's a mentor, I'm a mentor, and it's nice to learn so many points from you on what we can do to our mentees. To give them space to grow and to help them grow, be more sensitive and more considerate, considering right now the generation is Gen Z, right? They are not like us. It's the
Yes.
Gen Z generation. We have to adapt to their requirements more often.
And it's actually something you learn on the job. Like
Yeah,
you
true.
you're
Yes,
not
absolutely.
equipped with skills to do that.
Yes,
Yes.
yes.
So, Dr. Anuja Java, so we are coming to the end of this interview session. The last question is for you. Are there any strategies that are in place for you to prevent the recurrence of glomerular disease in a transplant patient?
Right. This is actually and Dr. experience from our institution on a specific genre, which is TMA. And what that example has shown us is exactly what you asked. And we learned it the hard way. We learned it when these patients actually had recurrences, like I was mentioning earlier. And what we understood over these years, it's really a combination of all these years of work, is that what we do now is actually trying to identify those patients in the pre-transplant setting. During pre-transplant evaluations, we'll do more hybrid, so as to be able to prophylactically either treat them or monitor them closely. And very much in line with what you were talking about hypertension earlier. Interestingly, our work showed that what we found was that we had about 70 patients who had thrombotic microangiopathy, and 42 of them were complement-mediated TMAs based on genetic testing, and 50% of these patients had a diagnosis of hypertensive nephrosclerosis as a cause of end-stage kidney disease, or preeclampsia as the cause of end-stage kidney disease. And so now, and these were the patients who we assumed had hypertension as leading to kidney failure. They get a kidney, they lose their kidney. And that's when I was talking, we identified mutations, we tested them, we kind of put the puzzle together. And so now what we do is actually when we see these patients in the pre-transplant clinic, the moment we see a diagnosis, at least in younger patients, and I say younger, our data show anything less than 40, so 20 to 40-year-olds, if we see this diagnosis, first of all, we don't buy the diagnosis, we do genetic testing. Young women who had preeclampsia and who've lost a kidney after pregnancy, which should not be the case, preeclampsia gets better, or other people we test. And so the other high risk groups are if they have a family history of disease, young patients who, kidney, disease of unknown origin, and an aggressive course. So because we try to test them early on, and we identify these patients, so that's at least one strategy from a complement mediated disease standpoint that we are able to identify. And maybe we sometimes use anti-complement therapy prophylactically at the time of transplant to prevent it. Of course, I think you can't fully extrapolate it to all GMs, but I think that's kind of, at least from my perspective on the field that I do, that is definitely something we've made a huge progress or huge dent terms of finding these issues.
That's a fantastic paper. It was really good to read because it answers all the questions that we've always had in our minds. What is behind this hypertensive kidney disease? What is behind this TMA? So it's really a fantastic paper that's come up from
I think it
your
should go
team.
into our transplant research, I mean, pre-transplant workup protocol
Yes.
to do genetic testing in India in someone like
Yeah, and
high risk
I
population.
have to applaud the reviewers of the paper. I mean, I really think reviewers do an amazing job. They don't get any credit for the free work they do.
Yeah.
But I was impressed on how thoughtful and insightful the reviews were. In fact, the reviewers, even though we had crossed the word limit, they wanted me to put a whole two-paragraph in discussion asking exactly to define a strategy on how to present these diseases. So
Wow.
it has gone into the discussion for that reason. And so I think it's really brought the paper together very well.
Superb. It's really superb.
So what do you suggest? We have to add whole exome sequencing and MLPA
Yeah. So
or
not
chromosome
right,
microarray.
right, not whole exome. So for the high risk groups that I'm talking about, we will do targeted, the
Targeted.
sequencing for complement disease. Because at least for this group of patients, this is what we found. We have the expertise, we have the experience. Even if we find variants of uncertain significance, we have a lot of understanding of what these VUS mean. I collaborate with structural biologists. We've done so much more functional testing wise over the years that we really can understand what these mean. And also, I currently co-chair a ClinGen. I think you mentioned earlier in my introduction, it's a gene curation panel. So we meet every month, sometimes twice a month, and we go over all the genes, and we'll be doing a variant curation panel as well. And so our understanding of genetics in complement diseases has grown and will grow tremendously. So from that perspective, we feel very confident doing sequencing just for the complement panel, and then including the NUPA, like you mentioned, and being able to find the information.
Fantastic. So for the lack of time, we should close this session. It's been a real privilege to talk to you, both of you, and hear about your work. We thank you for your time and your valuable insights. And we are really looking out for how your research is going to shape and impact the future of nephrology, because you both are working in areas that are very crucial to nephrology in the real sense, bench to bedside.
Thank you
Thank you.
both for
Thank
having
you
us.
so much, Professor Vivek and Professor Anuja, for sharing your valuable time with us.
Thank you so much for having me.
Thank you.